and clinical investigation course. He's board certified in infectious diseases and specializes in treating people living with HIV. Prior to joining the Owing Clinic, Dr. Deiss was a research and staff physician at the Naval Medical Center, also here in San Diego, where he led studies on neurocognitive impairment and cardiovascular disease amongst people living with HIV. And also recently, he spent a year in Mozambique through Doctors Without Borders. And there he primarily treated patients with advanced HIV and related diseases, including tuberculosis, cryptococcal meningitis, and Kaposi sarcoma. His current research interests include the intersection of HIV and substance use disorders and sexual risk behaviors. Today, he will be presenting on cryptococcal antigen screening in research-limited settings. So please join me in welcoming my colleague, Dr. Deiss.
All right. I'm unmuted. Thank you, Dr. Bamford. And thank you, everyone, for joining. I think it's a small group, and I know almost everyone here, so that's always nice. I will say and apologize that you know, I gave this talk at a Owen rounds at a high rounds earlier in the year. So you know, if you've seen that, I don't have much new data to show. Feel free to either peter out or multitask. But for those who haven't seen the talk, I hope you enjoy it. And so I'll just go ahead and get started. Let me play with my screen, and I'm just trying to advance. Here we go. Okay, so I have no conflicts of interest or anything to disclose. And so what I'll do today is provide an overview and rationale for screening for cryptococcal antigenemia and meningitis. And as part of that, we'll talk about point of care diagnostics that are helping really facilitate screening and make this available worldwide. I'll talk about some new directions for the treatment of cryptococcal meningitis, which are very exciting, particularly as they relate to resource-limited settings. And I'll share a little bit of my field experience that I had with Doctors Without Borders, Médecins Sans Frontières for the French speakers among us. And okay, so cryptococcal meningitis, it's a very important disease, obviously, worldwide, with over 200,000 cases and nearly as many deaths. It's the leading cause of meningitis in Africa to this day, and is responsible for about 15 to 20% of AIDS-related mortality. In resource-limited settings, the disease-related mortality is especially high, even with treatment up to 50 to 70% in many settings. And sadly, there's really no sign yet at this point of slowing in terms of these high rates, despite the scale up of antiretroviral therapy programs worldwide. And as we'll see, that one of the themes you'll see in this talk is that many patients with cryptomeningitis are in fact treatment experienced. And so it speaks to the need for screening and treatment. So why do we screen for cryptococcal meningitis? Well, for the last several decades, we've known that the antigen is detectable in blood weeks to months before the onset of meningitis symptoms. And in this study in 2004 in Uganda, what the researchers did was take samples that they had stored on baseline samples before people had started ART, and looked at, well, what was the proportion of people who had cryptococcal antigenemia and what were their outcomes. And so among those with the CD4 of less than 100 and no known or suspected cryptococcal disease, almost 6% had antigen positivity. and they actually had a very high relative risk for mortality as well. There were almost as many deaths from cryptococcal disease, again, in this asymptomatic group than there were for tuberculosis. So it's been known for some time that screening is important and can detect the antigen before symptoms or disease. And that's why it's important to identify at the time of ART initiation or reinitiation to prevent the sort of unmasking iris immune reconstitution phenomenon. So in our own IDSA primary care guidelines, testing for serum cryptococcal antigen can be considered in patients with CD4 count less than 100 or in patients with symptoms. Now, ironically, this is under the heading tests not recommended for general screening purposes, but as you see in the right setting, there is a role in the US for screening. And some of this is based on this some of these large cohorts, including the MAX and the Women's Health Interagency Study, where about a 3% prevalence was found among patients with a CD4 less than 100. As far as resource limited settings are concerned, these are the WHO guidelines, which were revised in 2018 and focused on settings with a high burden of cryptococcal disease. Very similar. Screening was recommended prior to ART initiation for all individuals with CD4 less than 100, and that was a strong recommendation with moderate certainty evidence, and also a CD4 less than 200, and that was a conditional recommendation with moderate certainty evidence. That is sort of the step one of the screening, and step two is if someone is positive, then a lumbar puncture is recommended, and preemptive therapy also recommended if their CSF is negative. What is a good threshold for screening? 100 cells, 200 cells? This was a meta-analysis in 2018 that pulled together data from any number of countries over about a 5-year period and looked at varying prevalence rates in each subgroup. So among patients with a CD4 less than 100, 6.5% were had cryptococcal antigen positivity. Among those with a CD4 between 101 and 200, it was 2%. And that was as high as we saw in the United States among people with CD4 less than 100. So as you see, if we screen only at the threshold of CD4 of 100, we would be missing 20% of cases. So that sort of underlies and really strengthens the recommendation for including individuals up to even a higher CD4 count. And this was sort of the big slide in the meta-analysis. And I'll point out a couple of things that, depending on the region, this is the African nations with, many studies, 37 studies, and a pretty high prevalence at 6.7%. I wouldn't make too much out of this. This is the Western Pacific region. There was really one study in Cambodia that contributed a very high prevalence. But as you see, this is a pretty wide confidence interval and fewer patients. But as we see, again, as I mentioned before, really not much of a difference in terms of, antigen positivity among people with, who are ART naive or treatment experienced. So then what might we say is the, benefits of screening? Well, it actually, there's data from randomized controlled trials that there actually is a mortality benefit. So this was sort of one of the hallmark studies in Tanzania and Zambia, which looked at an intervention that included cryptococcal screening. There were 2,000 individuals with a CD4 less than 200. Some of them received the standard of care, and others received cryptococcal antigen screening, preemptive therapy, and enhanced support in that. So in the group receiving the screening, there was a 28% reduction in mortality among people that received the intervention, and 4% were serum crypto antigen positive. So even in sort of a, I mean, 4% is not it's not low, but it's not screamingly high, and even there was still a mortality benefit. So that underlies, some of the heart of the recommendation. And there's also data that crypto screening is very cost effective. So any number of studies that have looked at, this issue have found that, crypto screening in the top study is even cost effective at low positivity. The cost per result is only $4 to $6 per case, anywhere from $25 to $100, and cost per life saved, around $300. So, again, many studies showing cost effectivity, and in sort of a meta-analysis of a number of settings, it appears that screening individuals with a CD4 less than 100 would cost less than $1 million, or be a very small period, a small portion of country-specific budgets for HIV treatment. So the second part of the guidelines, unfortunately, screening, as we'll see, has not been taken up universally for various reasons. And so if screening is not available for whatever reason, then WHO recommends fluconazole prophylaxis for individuals with a CD4 less than 100, and that it can be considered for individuals with a CD4 less than 200. And so why not, the question sort of might come up, well, why even bother screening as opposed to, just providing fluconazole for everyone with a low CD4? On the pro side, it's a tolerable medication, especially at low doses. We would have a mortality benefit potentially. I'll show data in a second. But, it's important to remember that, fluconazole medication is not necessarily universally available. It's frequently subject to shortages, in which case you'll need to reserve it for people with, actual disease, meningitis, or at least, people with cryptococcal disease, rather than sort of a wide population-based approach. There are some toxicities and drug interactions, especially when we're talking about anti-TB therapy, in terms of liver toxicities. Just a pill burden of, where avoidable, it's always nice to start fewer medications. And there is some evidence that fluconazole resistance is increasing. It's still very sort of small and limited, and there's not a whole lot of data, but it is something that is occurring and being seen. So, but let's look at the evidence on whether or not this should be done. So this is a Cochrane analysis, several years ago, looking at the question of fluconazole prophylaxis on a universal, sort of approach. And here the conclusion was that there was little to no difference in all-cause mortality, and that included 6 trials with over 3,000 participants. But it notably, universal prophylaxis did reduce the risk of developing cryptococcal disease in a number of trials, and probably reduced the deaths due to cryptococcal disease. So, this is a sort of a, not unusual Cochrane review where, the overreaching point and conclusion is or hypothesis is hard to support, but there's a lot of evidence that it actually is maybe something worthwhile doing. I think a lot of that has to do with the selection of trials for this review. Many of the studies were done in an era before sort of targeted screening approaches, and some of the dosing for fluconazole is all over the place, and it might have been for candidiasis, et cetera. So, there's not a lot of great evidence, even in the trials that are included, but there's enough to support, the risk of, there's enough to support risk reduction for preemptive therapy, at least. And then more definitively was the reality trial in 2017, which looked at, sort of overall enhanced prophylaxis for patients beginning ART in African settings. So this was a study that examined 1,800 patients comparing standard prophylaxis, which at the time was trimethoprim sulfa and isoniazid for PJP and tuberculosis, versus an enhanced sort of therapy, which included those same drugs, along with fluconazole, along with azithromycin and albendazole. And so there were additional trials, there was an additional arm of the trial which compared the effects of adjunctive raltegravir and food supplementation. I won't talk about those, but what you'll see in the sort of tables here and in the graphs is that this is mortality on the y-axis. So the group that was receiving this standard prophylaxis, which did not include fluconazole, did a lot worse and had significantly higher mortality at the 24-week endpoint, which was the study, primary endpoint. And that, mortality sort of risk was sustained throughout the entire study. As I said, fluconazole wasn't the only intervention that was provided, but as you'll see, there wasn't really any difference in terms of, bacterial infections or sort of unknown or other infections. But where we did see a marked difference was in people who were receiving the fluconazole prophylaxis without surprise had less cryptococcal disease. So really the difference that we're seeing was being driven by two things. One was this cryptococcal sort of benefit, and the other was in this category, the unknown. But I'd posit that maybe even some of those individuals had fungal infections that were being treated. So anyway, this has been an important study that has somewhat supported that recommendation of fluconazole, even if you're unable to screen for cryptoantigen. So basically, to conclude, screening and fluconazole therapy are highly effective. So I'll talk about what it might look like in an African setting. For anyone who knows me, I sometimes pepper my talks with musical references, and I won't quiz anyone, but maybe someone wants to holler who those artists are. And I'll give you 3 seconds. Those are the Pointer Sisters for our point of care diagnostics. So the reason a lot of this has come up and is has been worth looking at is that there is now a really good and easy way to test for cryptoantigen, both in blood and in the CSF. And it's this small kit that's really the size of like a half of a shopping bag or so, and it includes all the supplies that are needed for testing. So basically, it's a qualitative test. You take a small amount, 1 drop of the actual specimen, add a little bit of it to the strip. It's basically like a pregnancy test. It's a lateral flow assay. You get 2 lines in the control, and if you get a control line, and if you get a second line, then that's a positive test. So it takes 10 minutes. It's point of care. And can be done very simply with sort of minimal training among laboratory personnel as well. So it is an FDA approved point of care dipstick test. As I said, no laboratory infrastructure is really required, just sort of clean open space on a table. And this is something that really semi-skilled healthcare workers can perform in clinics or even at the bedside. No refrigeration is required, and you get results in 10 minutes. So this was among one of the early studies that validated the lateral flow assay as a reliable means for diagnosis. And here it is compared to, sort of other modalities. And what I think is really important is that the sensitivity and specificity are, as you see, extremely high. And their sensitivity is even higher than culture, which would be the gold standard, obviously, for diagnosis. So it's, not only is it a point of care, but, unlike many, we don't actually sacrifice any of the quality of the assay. It actually, it winds up being superior to many of the other methods. And then this is sort of a study which shows a Venn diagram of the sort of implications of this. And basically all I would want to show you is maybe in this table here, which is that, again, the cryptoantigen lateral flow assay is this 99.3% sensitive, and it shows that we would miss some of these cases if we were only doing cultures or India Inc. And you see there's very few, there's only, this is the lateral flow assay, this blue turquoise circle, and there's only 0.5% that fall outside of its Venn diagram. So, very, very effective screening tool. And this slide, this shows you, actually it's a table of those individuals who didn't, who were diagnosed by a means without the lateral flow assay. And what you see is that, many of them began ART and went on to develop cryptococcal meningitis later. So it was something that was maybe difficult to diagnose up front anyway. So let me just shift gears one moment and point out an additional benefit of screening, which is that it can detect cases along those lines even before people present with symptoms. This was a sort of a study from a registry where the authors kind of looked at, well, who are the people that were dying with meningitis and what did they have? And so they took 1,200 people that had symptomatic meningitis. A number of them were diagnosed with cryptomeningitis by typical means. They were serum positive and then they were CSF positive, but many of them were CSF negative, which is interesting because, well, then what is their diagnosis? Why do they have meningitis? When, you used other methods, to make a diagnosis, 5 individuals of the 54 were found to have cryptococcal meningitis either by culture or by PCR. There were 6 individuals in this group that had TB meningitis, which is sometimes hard to diagnose. But there were a number of people with no other identified etiology, and that was by using PCRs. And what was interesting was that in these patients who were serum CrAg positive but CSF negative, the mortality in this group was actually similar to those who were diagnosed with cryptococcal meningitis. So there's something about, cryptococcal antigenemia that's a herald not only for meningitis, but actually for just a poor outcome. And so the authors sort of call this phenomenon, it's not really well described, but that there is something called cryptococcal antigenemia with meningitis symptoms, where the CSF might be negative for whatever reason, but this person might have actual disease, whether it's already invaded the brain parenchyma or in the form of cryptococcomas, etc. That can occur, but even still, important to note. So, I've only showed you the, cryptococcal lateral flow assay, but it's important to know that in many of the settings where this tool might be used or studied, there's additional point of care testing that can help with, deciding who should be screened, et cetera. And those are CD4 and some of the electrolytes and hemoglobin, obviously, and a urine assay that can help detect the presence of TB among people with very low CD4 counts. So this is the CD4 machine, and we were using this in Mozambique. And basically, I just want to sort of show the picture. And this is from the CDC website, which shows that it can bring life-saving treatment one step closer to people living with HIV. And in the text, they describe this as the size of a large toaster. So again, very, very sort of easy to set up in a small lab. I'll talk now about treatment, and I'll just give this one away that's Pat Benatar, who has a song called Treat Me Right. And then these are the Cornelius brothers and Sister Rose, who have a song called Treat Her Like a Lady. So shifting gears to treatment. The reason, treatment of cryptomeningitis, I mentioned earlier that even with treatment in resource limited settings, mortality is very high. And that's because it's logistically challenging, among many other reasons. It requires long treatment regimens with frequent dosing and monitoring. In our guidelines, it's 2 weeks with amphotericin, with CSF monitoring, flucytosine as well, which is administered 4 times a day. So it's an intense regimen to take. And aside from sort of the logistics involved, fluconazole and especially flucytosine are not necessarily widely available. Flucytosine is in all the first line recommendations for treatment, but unfortunately, only 1,000 out of about the 160,000 of patients in Africa with cryptococcal meningitis receive flucytosine, again, which is a first-line medication. Another challenge, obviously, includes health systems which are poorly funded and sometimes inadequate. And as I mentioned, even when this is diagnosed, it still confers a very high mortality. So this was a seminal trial a few years ago that really informed the guidelines for cryptococcal meningitis treatments, and the so-called the ACTA trial, which included 700 patients in 9 centers and compared 5 different treatment strategies. Amphotericin in most groups with either flucytosine or fluconazole for 1 week, or amphotericin paired with flucytosine or fluconazole for 2 weeks. All these 4, regimens, and also a 5th regimen, which was did not include amphotericin and just had flucytosine and fluconazole for 2 weeks. The advantage in this group being that this is a strictly oral regimen. Both fluconazole and flucytosine can be, can be administered orally. The sort of primary endpoints of this study were 2-week and 10-week mortality. And it was pretty striking that that we didn't see differences in many of the groups. In other words, at 2 weeks, there was little difference in the, and even slight improvement, although not significant, in the oral regimen compared to the 2 weeks of amphotericin regimen, which again, here is sort of our standard of care, and had been at the time, but even it looks like a shorter course was able to confer a similar mortality benefit. And in the 10-week mortality, very similar story, that there was really no difference between the 2 weeks, 1 week, or just the oral regimen. And so why is that? Well, it looks like actually flucytosine, again, the one I mentioned that, is often scarce, really is sort of the hallmark medication here, that if you compared the patients who received amphotericin with fluconazole versus flucytosine, the patients who were receiving flucytosine did better even at 2 weeks, all through 10 weeks, etc. Flucytosine looks like it's critical, and that's why even the oral regimen did very well. So this was a critical study in terms of simplifying treatments. Having an oral option, even if it's often scarce, is great for patients with kidney disease as well, who might not be great candidates for amphotericin. It's great to have an alternative. And frankly, again, the shorter course of therapy, allowing for equivalent outcomes is in some ways game changing. That informed the WHO treatment guidelines, which recommend as, sort of the first line recommendation being a short course of amphotericin B, the 1 week with flucytosine for 1 week, followed by a high dose fluconazole for another week, and then consolidation therapy, et cetera. Alternate regimens include this 2 weeks of fluconazole with flucytosine, the oral recommendation. And, again, if these aren't available, then you have to give something, would be ampho and fluconazole. But the first two are really the preferred regimens. And then I mentioned consolidation, a long phase of fluconazole. And again, as you see, at 800 milligrams, that tends to be like 4 tablets a day. And in these high prevalence settings, that's a lot of fluconazole that's being administered. And so again, so then this is an additional promising strategy that right now is in phase 3 trials. But a few years ago, the phase 2 data came out for just a short course, high dose liposomal amphotericin regimen. And so there were 4 dosing strategies in this study, which included some patients who only received 1 day of amphotericin, and others who received, 2 doses on day 1 and day 3, others who received 3 doses, and others who received our standard of care of 14 days. Their endpoint was rate of clearance of CSF infection by culture. All regimens included 1,200 milligrams of fluconazole a day. But just to skip to the bottom line, this single dose regimen was actually, there was no statistically significant difference in mortality between all the arms, including just comparing the 2-week version versus the single dose. That high dose was well tolerated and non-inferior. And so it's again, sort of really advantageous to think about, a regimen which only requires a single IV administration. It can even turn cryptococcal disease management into an ambulatory setting or a quasi-ambulatory setting. And I'll show you what we were doing in Mozambique along those lines. So again, this is in phase 3 trials, but I think is a very promising strategy for resource limited settings. So additional research priorities right now are, sort of simplification regimens, including flucytosine to dose it at a Q12 interval rather than Q6. It's hard to take medication 4 times a day, we all know. So, having something that can be given sooner or fewer times per day would be very helpful. A lot of work being done on sort of the management of immune reconstitution, which is often very challenging in these settings. Some research on fluconazole resistance. These are sort of some of the research priorities that are frequently identified. And I'll show you one of our care delivery models, which was in Mozambique, a project I participated in for a little over a year in 2018 and 19, just before coming to UCSD. A lot of people, had, sort of a certain image of what it's like to be in Mozambique, not necessarily here among UCSD, where many folks have been back and forth, and we have great ties with their institutions. But, I definitely like to always show this picture of me on a weekend in Mozambique, because, this was not necessarily me suffering in Africa, as some people might have been led to believe. And I like to think of Maputo actually as kind of the San Diego of Africa. If you see here, this is a view of the city from the air, from an airplane. Doesn't this look like here the Coronado Bridge? Actually, that's the Katembe Bridge, and this is not the island of Coronado. This is Katembe. And so this actually is their Catholic cathedral, looks like our cathedral on the 5. And I'm hard pressed if you showed me this picture to say if that's the view from the convention center or this area in Maputo. So very similar. It felt like home. And this is the center where I spent most of my time, which was this sort of referral center that was a joint project between MSF and the Ministry of Health. So this was a center where accepting referrals for patients who really had like complicated disease if they had a low CD4 count, Kaposi sarcoma that required chemotherapy, hepatitis C, chronic kidney disease, or a complicated opportunistic infection. As part of the intake, when a patient was referred, they would receive counseling and education, which is often some of the most important intervention. And everyone sort of received that kit of point of care screening that I alluded to earlier, which included a CD4 count. And if someone had a CD4 less than 200, then they would receive the cryptoantigen screening and a TB-LAM, the screening for asymptomatic tuberculosis. That's disseminated. People would get a visit with a medical doctor, and if they were positive, if they tested positive for cryptoantigen in the blood, then they would have a lumbar puncture as well. So this is, I mentioned this briefly, but it wound up being sort of a quasi-ambulatory model of care. So if a patient was diagnosed with cryptomeningitis, what we were able to do, we would be able to administer treatment, right there in the clinic. This is a patient receiving a lumbar puncture where we're sort of measuring the opening pressure here. And so we would transport the patients to our clinic early in the morning. They could get sort of pre-hydrated, around 6, 7 a.m. And, just hang out in the clinic all day receiving the amphotericin infusion. And so, as we know, I mean, the patients, they receive the bag and, some pre and post hydration, and it takes some hours, and they receive lumbar punctures if they need them, but they don't necessarily need to stay overnight in the hospital. They could be transported back to their homes and return the next day for day 2 of treatment, and we would do this for 7 days. And this is sort of the protocol in Portuguese, which, as you see, includes like a weight-based dosing of amphotericin and flucytosine, and also like electrolyte monitoring on day 1, day 4, day 7, and LPs, done on day 1, day 4, day 7. If someone needed LPs because they had, elevated intracranial pressure, then we did them. But this was just the standard, like everyone received LPs on these days. And so what I'm going to talk about is a screening program that we employed I showed you the ambulatory center. So this was a program that we actually installed in one of the tertiary care hospitals, in one of the public hospitals. It's just sort of outside the city of Maputo, in a sort of outlying area that was not their central hospital. So this is the hospital here, and I just want to show what that actual point of care lab looked like. And as you can see, it didn't really take a whole lot of space. There's our CD4 machine. This one was the electrolytes, I think, and then this is where we did the crypto screening with the little stopwatch and some of the test tubes, etc. So really only a small space was needed. I think this was a converted office, that was adjacent to the larger laboratory where we were able to do this testing. So what we did in Mozambique, this was sort of a demonstration project of MSF to examine what point of care screening might look like in an emergency department setting. So we sort of did the project and then looked back at what our experience was. And so I took a look at data that was collected over the course of a year, and that included about 2,200 patients that were present in the emergency department, 1,800 of them who received CrAg screening based on their CD4 count. And so what we found overall was that 7.3% had serum cryptoantigen positivity, and we were able to diagnose 96 patients, or about 5%, with cryptococcal meningitis. And that's done, I want to again point out, on day 1 in the emergency department, as opposed to like day 3 or 4 or 5 waiting for culture to come back. So early treatment really very possible and critical. So this is a sort of look at what our patient population, how it compares with others. And as you see, this was a low CD4 group, with CD4 of 79 on average. Not surprisingly, the individuals who were serum CrAg positive had lower CD4 counts, but even in the 30s and 40s on average. And again, I mentioned this earlier, that a number of them had been on treatment, right? So the median time on treatment for patients with who were serum CrAg positive was 1.4 years. Some were only very newly started, at a couple weeks treatment, sort of indicating a new diagnosis or an unmasking diagnosis. But as you see, this is the quartile for 75%. This means that 1/4 of patients had been on ART for more than 5 years, which is very striking. And many of them were coming in with cryptomeningitis, as we see in this column. So again, a sort of very sort of sick population that was receiving care in the emergency department, many with advanced disease, and many who were treatment experienced. So then I spoke about thresholds earlier for screening. As you see, the highest prevalence was in the group who had a CD4 count less than 100. But even among the individuals with the CD4 less than 200, again, a pretty high percent, 4.5%, and 8 individuals, or 2.6%, with meningitis. Now, who are these individuals and why were they getting screened? We also were screening by CD4 count, but also if someone had symptoms. So if they had meningitis or abnormal vital signs, or abnormal or an altered mental status, they received a sort of the full kit of screening as well. And we also found that 2% of those individuals had cryptococcal meningitis, even with a high CD4 count. So this is what we were, hoping to really define were our treatment outcomes. And as you see, I sort of have gone through our flow already, with everyone being screened. And these were the people that were cryptoantigen positive. And of those who received LPs, 96 or 71%, had cryptomeningitis. So we wanted to see what happened to this group in particular. And what we found was that a number of them died during the hospitalization, from their diagnosis, often presenting very late in the course of illness. But the majority were discharged after having received at least 1 week of treatment. Some individuals, some of the physicians, by practice, like to extend the course of amphotericin, even though we sort of discouraged it. But everyone generally received 7 days, and a few people received a little bit more. Everyone was receiving lumbar punctures as well, if they were symptomatic or had elevated opening pressure. And so what we wanted to do was then look at our sort of ongoing outcomes. If someone was identified in that emergency department as being, as having cryptomeningitis, what was going to be the outcome when they were referred back for ambulatory care. So what we found was that 38 or 60% of individuals were still alive and receiving care. An additional 9 patients had died in the 12 weeks following their diagnosis. often from, iris and immune reconstitution, but often from other, illnesses like disseminated TB, etc. And unfortunately, a number of patients were lost to follow-up. So, this was about, what looks to be a 40% mortality if we combine the deaths and loss to follow-up overall. So again, I mean, even in this setting, I didn't mention in the ACTA trial, even with in a clinical trial, mortality was still upwards of 35–40% at 10 weeks. And in our setting, even with, sort of transport and care and NGO support, we still had very high mortality as well. So, to summarize what we found, again, a high prevalence of cryptococcal antigenemia and meningitis in Maputo at all CD thresholds, and even among those individuals with CD4 counts over 200. Mortality attributed to crypto was unacceptably high, even with available essential medicines. All these patients, like I said, were receiving amphotericin and flucytosine. But I would still say that this sort of quasi-ambulatory model of care does offer potential for, overtaxed public hospitals. We were able to sort of take many of those patients on for treatment, or if they needed reinduction at some point, they could receive it in our center. They could go on to receive, sort of consolidation therapy and lumbar punctures at our center. And so it did offload sort of inpatient care of cryptomeningitis to a degree. But I think it's safe to say that if we had better screening and utilization before the emergency department, that would be ideal. And so that's what we're really trying to stress, by having point of care resources available. So this is a publication summarizing our experience. If anyone would like to look it up, or I'm happy to provide and share a copy at some point. And I think that's it. I would just, acknowledge our team. This was the team at the hospital, Jose Macamo, in the emergency department team. And obviously, nothing could be done without a great sort of team in place. I think that's all I had, and I'm happy to, I included the playlist if anyone would like to hear the songs that I was referring to. I'm happy to take questions either in the chat or by unmuting anybody. So here's a question: if we could identify rates of elevated CSF pressure or other OIs as causes of death. Yeah. So I don't think we did a sort of mortality analysis of the patients who died, but I would say probably the two big causes were, immune reconstitution. The WHO guidelines recommend initiation of ART within 4 to 6 weeks after a crypto diagnosis. And that feels like it might be a little early. I think the people often in our clinic who had really advanced disease, had very high opening pressures, and maybe needed longer than the 4 weeks between diagnosis and initiation of ART. So I'd say we had a lot of immune reconstitution, unfortunately, especially early in the sort of study period, and then maybe disseminated TB would have been our second leading cause of death, or just sort of the interplay between advanced HIV, disseminated TB, and TB iris, etc. But yeah, thank you for the question. I don't know if people are tired of hearing me talk, so maybe I'm not sure if Kimberly has anything, or if anyone would like to unmute and just share their experience or knowledge as well.
Well, thank you for joining us today. I don't have anything further, so.
Yeah, again, I appreciate, I know some of you might have seen this, you know, some of this data before, but I thank you for joining and sharing, and happy to talk offline or hear if anyone has anything additional or would like to learn more.
One other question, Robert. This syndrome of antigenemia with meningitic symptoms and then no CSF positivity, have those studies looked for other sites of cryptococcal disease in the lung, lymph nodes, and that sort of thing?
Yeah, not really. Not the one I referred to from CID, I think was just exclusive to the CSF, and you know, using PCRs to sort of make that diagnosis on the presumption that someone died, you know, with meningitis, I guess. But yeah, they weren't necessarily staging or surveillance or full autopsies as part of that. Yeah. All right. Well, I think that's all. I'm happy, you know, it's an honor to be part of the CFAR and these seminars, and I hope that you know, this has been an interesting experience for people, as it has for me.
Thank you.
Thank
All right.
you.
Thank you.
Thank you.